Hmm. Hello, Heidi. How are you doing?
I'm well, Sergey. How are you?
I'm fine. Thank you very much. Thank you for joining me today. This is been long-awaited session of me wanting to talk to you about some nursing stuff, which are very pressing to mostly everybody. And I've been speaking to you before, and I realized I wanted to share those pieces of wisdom with everybody else. I've been talking to many, many nursing leaders, and I think it's about time we, shared some of this knowledge. And I'm happy to be here with you.
I'm glad to be here with you too, Sergey.
Awesome. So just a quick round of introductions. My name is Sergey Vasilenko. I'm a Chief Nursing Officer of In-House Health. We built and implemented a predictive scheduling platform that helps nursing leaders to save money, reach better outcomes, and prevent burnout among nursing staff by better utilizing their existing workforce in-house health. And today with us, Heidi Zedlar. She has driven healthcare excellence through her focus on leadership and problem solving, enhancing patient outcomes and operational efficiencies. Her expertise in quality outcomes and networking has strengthened partnerships and cultivated a culture of continuous learning and compassionate care. Heidi also advises on and has partnered with several ambient AI healthcare companies to assist with nurse retention and patient outcomes. This is very impressive, I must say.
Oh, thanks, Sergey.
So,
It's been a long time.
oh yeah, oh yeah. So there's so many things I want to talk to you about, and obviously we can't cover everything on one session. So we had to select two topics, and one of the topics I wanted to talk about is leadership in time of crisis. I don't even want to go to a point where I'm discussing if there is a crisis, because we all understand there is a crisis, and we are being hit by a perfect storm. But I want to kind of brainstorm about things like how strong leadership can mitigate staffing shortages and prevent burnout. And if I if I'm to start from the end of the problem, not from the beginning of the problem, I would probably ask something like, what are we getting wrong about healthcare leadership? What common mistakes do nursing leaders and hospitals do while managing nursing teams?
Well, I'm glad you asked that, Sergey. So, when it comes to healthcare leadership, what I've noticed is one of the biggest missteps that I've seen is treating nurses kind of like a cog on a wheel in the machine instead of humans that have actual limits. We all have our limits. So, hospitals often too much lean on the do more with less strategy, like it's some kind of noble honor that they can get more done with less. Leaders push, I don't know, mandatory overtime for some of their staff. They skip over the most important part, which is their staff's input. And they assume that they can just tough it out, but they don't. That is the pure recipe for resentment and burnout. Another mistake I see being made is focusing too much on the metrics, like patient throughput or their bed turnover, when they ignore the most important thing, and that's the morale of their people that are keeping the entire system afloat. Now, to me, that's like polishing a car when the engine doesn't run. That's what I think is important.
I love your analogy as polishing a car when the engine is smoking.
Yeah.
That's so much true. I mean, people are often, well, some would try, some you can justify that looking from the top of the pyramid of huge organizations, corporate, and so on. You want to check your metrics, you want to see your income, you want to see your outcome, but eventually this all has very wide basis, which is often outlooked. And like you mentioned, it's a morale of people holding the pyramid together, making it not falling apart. But
Yes. I feel like if you take care of your people, they'll take care of your metrics.
now this is a problem. Okay, and if we are to pretend that we are very sensitive and very thoughtful and very proactive leadership, what could we do to help to help the situation in a reality where we simply don't have enough nurses? What practical things can leaders do to support their staff?
I have so many avenues I could go here, but yeah, it's absolutely brutal out there. When it comes down to the bare bones, Sergey, leadership has to be both creative and proactive. And I'm going to harp on this one, but transparency. Tell your staff what is happening. Tell them why they're short staffed. Tell them why everything's insane, but also tell them what you're doing to fix it. Nurses aren't fragile, but they don't like being left in the dark. They don't look at that as a good way to be a leader. Second, prioritize the workload triage. Figure out what can wait and what can't, and shield your staff from drowning in the non-essential tasks. Maybe that means pulling in float pools or temporary staff for just a minute, or even admin support to help with the overflow of paperwork that's being dealt. Third, the small wins matter. And what I mean by that is be visible to your staff. Don't just sit in your office. Bring them coffee, give them little breaks, say thank you. Thank you goes a long way in a way that feels real. It's not just about fixing everything overnight. That can't happen. It's about showing that you've got their back while you hustle to get them the reinforcements they need to continue. I'd also like to talk about some of the, for me, promising models out there that are making waves today, especially with the adoption of AI technologies. There are three companies I'm going to mention that I've either been a part of or have done extensive research on. Commure, In-House Health, and Patient Voice come to mind for me. And I'm going to start with Commure. It's a company out of San Francisco. They're partnering with technologies that have massive systems uptake, like HCLA Healthcare, to deploy one of the largest AI rollouts in healthcare history. They cover over 188 hospitals and 99,000 nurses. And yes, I said 99,000. Their ambient AI suite tackles the documentation nightmare head on, saving nurses up to 3 hours a day of charting. In fact, I heard about one doctor at Dignity Health who cut his time by 25% using Commure's tech. So eventually, this is all more time for patient care. Can you imagine the staggering positivity coming out of those patient satisfaction? So next, I want to touch on in-house health. It's another big player in using AI to rethink staffing from the ground up. They focus on building smarter, more responsive staffing models by leveraging data to create what I'd like to call the in-house solution. Think of it as an internal flow pool, kind of on steroids. Their platform uses AI to predict, staffing gaps. Predictive AI staffing is one of the up and coming things in healthcare. They pull from the hospital's own trained staff instead of relying on expensive agency nurses. It's a win-win for continuity. Nurses already know the system and the patients, so there's less chaos. In-house health also uses AI to optimize shift assignments based on nurse skills and patient needs, which means they're not just throwing a random temp person into a high acuity unit. That's the kind of precision that reduces stress and keeps nurses feeling supported, which is a huge win for retention. And the last model I want to talk about that I heard about recently was the patient voice. Now, I didn't so much get to view their model, but what it does is it is allowing the patient to have a voice, just like it says. So it doesn't matter what language the patient speaks or the caregiver speaks. It understands it and delivers it to the caregiver or the staff in whatever is their preferred language. So what it does is it's an approach where hospitals use the AI to collect real-time feedback from their patients about care and experience, then feed it into the staffing decisions. For example, if the patients on a unit are reporting long wait times or missed care, like not getting to the bathroom fast enough, this system will flag it. And the managers can shift their staff into the unit as soon as needed. It's this paired with other AI tools like Commure or In-House that make this full picture happen. The patient feedback plus predictive analytics, so hospitals can stay ahead of the game. Nurses feel the difference when their workload matches reality. And that is what keeps nurses from burning out and walking away. You know, the impact is real and it's measurable, Sergey. Commuters work and in-house, as well as the others, are giving nurses back hours every day, which means they're not drowning in paperwork and can actually focus on their patients. That's a direct hit to burnout. In-house health is cutting reliance on staffing agencies, which saves money and builds a tighter team. Patients' voice ensures staffing isn't a guessing game, so nurses aren't constantly playing catch up. Together, all of these approaches are creating systems where nurses feel supported. They're not overwhelmed, and that's what keeps them in their job. It's not just about filling shifts, it's about making work sustainable.
Yeah, well, this is a great review of only several solutions out there. And I mean, if I wanted to summarize this piece, I would say technology is here to stay.
Yes.
It's only going to evolve more and more. The AI agents, the AI players out there, everything that all that is here and it's real. And we just, as people who used to be or still at the bedside, we probably need to be aware of that, because if you are adopted, maybe you shouldn't be the early adopter, but if you adopt it sooner than later, it
Yes.
gives you leverage and you can success in what you're doing, with higher level of success, and simply not be left behind, because it advances so fast and it goes so high, just you can be left behind very,
Yes,
very easily.
absolutely. It's so important to adapt to the up and coming
Yeah.
so that you can do what's best for your staff and your facility.
What makes great nurse leaders? What do they do different? What separates strong and effective leadership from, well, the poor one in the times of crisis?
Sure. I'd love to answer this one. I kind of look at it, Sergey, like great nurse leaders are like battlefield generals with a heart, though. They get into those trenches. They're not hiding in an office. They provide transparency and they're asking, what do you need and how can I help you? They actually act on those words. They're divisive, but flexible, which is also important. Like when you reroute the resources that you have to, cover a gap. Poor leaders seem to freeze or double down on bad plans. They hide in their office. They're not adaptable. They also build trust. Great leaders build trust by owning their mistakes instead of pointing fingers. It's not about pointing fingers, it's getting the job done together. And nurses notice that. And here's another little kicker: they protect their team's energy. They'll fight the C suite to cut dumb policies and push back on unrealistic demands. Poor leaders just pass down pressure down that line while strong ones absorb it and redirect it. And how I think of this is the top down approach versus servant leadership. So great leaders are often striving in the servant leadership style, Sergey.
I mean, protecting their energy is great. It's good stuff. I mean, I couldn't have put it better myself. Protect their staff energies, the unit's energy, the whatever energy, because
Yeah.
energy is one of the resources. When you say burnout, this is actually this you getting drained of energy, because you go to the shift and you see the misery, the sickness, the death. Well, you also
Yeah.
see many good things, but it almost always starts with the bad part, and then you absorb it, and then when you absorb it, your energy goes down. Now, how do you retain this energy of your team? Wow, I love it. I love this analogy. Um, let's move to our second topic for today, and I just want to talk about the human cost of poor staffing. Like, if you can share real stories of burnout, turnover, or elaborate a bit on how mismanagement pushes nurses away. If I wanted to be slightly more particular about what we want to talk about, I would say, what does like poor staffing really looks like on the ground?
No. Well, I'm going to elaborate this. And because I did my doctoral work in this area, I'm going to give you some statistics that may be shocking. But poor staffing on the ground is a true nightmare. I'm not saying that facetiously. It's like trying to keep a dozen plates spinning in the air while someone's yanking them out of your hands. You just can't do it. Picture a nurse, on a busy unit. They've already got 7, 8, 9 patients, but now 2 nurses call off. And that hospital's leaning on the temps that don't know the unit, or staffing agencies to fill these gaps that aren't doing, their share. That nurse is racing between rooms, meds are late, the patients are crashing, another family member is demanding answers because they didn't get what they asked for. And she's got no time to even grab a sip of water, go to the bathroom, or change her mind for all that matters. And the statistics on this are actually flabbergasting. And I'm going to share some of that with you right now. The stats back up how bad this gets. In the current research that I've looked at, I've found that by using staffing agencies, patient mortality jumps 12% when you use a staffing firm for just 1.5 hours or more of patient.
Wow.
Because they don't know the patients or the unit's rhythm. And that can be found in Delora et al. In 2019. And when staffing deficits hit 16 hours or more, which that happens quite frequently nowadays, mortality spikes yet again. That's no surprise. But filling those staff with an agency nurse doesn't even reduce that risk, says Zarenko in 2022. So that's why it's important to have in-house fill these positions. And it's also a mess to care for quality too. Bump up the temp staff by 20% and you get care left undone. And care left undone is missed vitals, delayed medication, dressing changes, and so on. And Senek et al. In 2022 put a great display of this together. Plus the ripple effect. More travel nurses from agencies correlate with longer patient stays. And with longer patient stays comes poor patient outcomes. There's a moderately strong link to this, says Polanich et al. In 2023. All of this chaos burns nurses out. And hospitals pay the price too. We can see a huge shift between shifting staff now. There's no middleman. It's top and then people touching patients because of this. But the research by Drenkert et al. Says if you just cut 20 travel or agency nurses, your facility can save over $3 million. Short staffing isn't just a bad shift. It's a cascade that hits the patients, the nurses, and the bottom line.
Wow, I just love numbers because nothing else tells the story, the real story better than numbers. And when you mentioned 12% mortality jump, only if the temporary nursing staff worked there like 90 minutes, I was like, what? What are you talking about? Is this thing real? I mean, just a little side story of my own. We all know that I'm out of country. I'm calling, and we're having this conversation across the oceans, which is great, by the
Yep.
way. I'm loving it. Nurses connecting across the ocean, but still, we don't implement this model here. So I've been doing shift management in tough ICU for only too many times, and I cannot imagine somebody showing at the doorstep and be like, hey, I'm here to work. And then I can now run this little scenario in my head where this person follows me as a shift manager because I'm the person to go and be like, hey, where are the syringes? Hey, where are the needles? Hey, where's the gastric tube? Where do you keep this? Where do you keep that? Who am I gonna call? What happened?
Yeah.
Call the Ghostbusters and leave me alone. Just go away.
Yes.
I mean, I guess it is working somehow and for somebody, but it is not optimal at all.
That's correct.
Okay, this is great stuff. I love the numbers, but could you share a moment when you saw burnout happen in real life, maybe of your own experience? What led to it? What could have been done differently?
Sure. So I've been in nursing for quite some time. So one of the vivid things that I remember, and I've been critical care, open heart and trauma, vascular access specialty, management. I've been all of those things. But one of the situations I remember vividly is one evening when I was just working on a unit. I'm going to call the nurse Sarah because I don't really want to give a name, but we'll call her Sarah, seasoned older nurse. She was kind of gruff and pretty tough. But one night we were working and she's on her third double shift in a row, short staffed again. Wasn't so hard for us younger ones, but for her, this took a toll. She was managing, I think, a post-op patient and they were crashing, and she had a dementia patient that kept running off, and the family was yelling about them not getting water. They're waiting for whatever they asked for. She's trying to hold it together, and our charge nurse comes over and tells her, I'm sorry, but you're going to have to stay late again and deal with it. I could see the light and the energy just drain out of her face. I watched it in real time. She finished that shift that night and she handed in her badge the very next day. And I keep thinking, what could have helped if that nurse manager would have stepped in with an extra pair of hands, or them saying, hey, I see you. How can I fix this? How can I help you? But that's not what happened. Instead, she got a shrug and the burnout was in real time. And I think this is like a death by 1,000 cuts.
Yeah, yet another great analogy. I mean, poor soul. I can only relate so much, but yeah, and let's jump to maybe something more optimistic here. We've been talking about the problems and how bad those things are. It's bad. I mean, for real. But have you seen, with your vast experience, have you seen like any staffing models that really worked? Maybe some innovative approaches, something that made a real impact?
Sure. Now, every unit's going to be different and every approach is going to have to be different. It's all individualized, but there is hope out there, right? One model that stands out to me is a team based staffing. Think of a core group of nurses paired with flexible support people like your CNAs or techs or cross trained float pool who know the unit, who can swoop in when, all hits the fan, if per se. I've seen hospitals also try pod systems. I see that a lot in the ICU telemetry units, small, tight knit crews assigned to set a number of patients, so no one's stretched across the whole floor. They're in their little pod. Another gem I think is now an up and coming is the predictive AI, predictive scheduling, using some of these data tools to spot crunch times like the flu season or beef up staff when there's a crisis or there's a lot of call offs. And none of it's perfect, but it beats reacting when the house is already on fire. A little proactive approach goes a long way. And as I mentioned earlier, some of the AI products are truly making their impact, assisting the medical staff and pretty much rehumanizing healthcare and giving those frontline workers some more time with the patients.
Yeah, I mean, about the thing about technology that always kind of makes me stop for a second and think about it. You can introduce as much technology as you want.
Yes.
And we all remember this transition from charting on paper to the EHRs,
Yes.
which I'm a great advocate for. I mean, it's all there, it's not lost. You can run statistics, you can always check up on things. It is great, but it took so much work and so much pain and so many tears and so much sweat and everything else, to have this technology established. And still some products are simply taking away time because you are obliged to chart and you need to do 1, 2, 3, 4, 5, 7,000 checklists and scores and all that and all that. When you're implementing technology, that side, you always need to remember that it has to be user friendly and take away your workload and not to add more to your workload.
And I do think that's what happened over time. Even though it became very productive, it also added a lot of time to charting. So
Yeah.
it's kind of refreshing, Sergey, to see these companies coming in and removing some of that charting time and do the predictive things to give nurses more time with the patient. So I'm very excited about that moving forward.
Yeah. Yeah. Let's talk about biases a bit and the myth about staffing shortages. Like, what do people outside of nursing don't understand?
Where do I start with this one? It's a good question. Uh, Big myth number one. I hear this one a lot. Nurses are just complaining. They signed up for that job. I've taught nursing, so they know they signed up for that job. It's just that they get overwhelmed by the things we've mentioned previously. And they didn't sign up just for a job, they signed up to help a human being, but not drown doing it. So people don't get short staffed. It's not just busy, it's unsafe. It's unsafe for the healthcare worker, it's unsafe for nurses carrying that weight home, it's unsafe for the patient, as I've mentioned the statistics earlier. Another one is throw money at the problem and the problem is solved. We know that's not the case. You can offer a bonus, and they're nice. They really are. They can be nice, but they wear off. So, what's something that's going to happen longevity to help nurses? If you're working 16-hour shifts and you have no backup, cash doesn't fix the crush of your soul that happens. Outsiders also think of this as a nurse problem, but it's not. Sergey, it's a system problem, a large system problem. Bad management cuts corners, and outdated policies are the real culprit. Antiquation can be the death of the nursing field.
Well, yeah, while you speak, I'm thinking, and I'm trying some stories come up in my head, and when I was a nursing student, and you just mentioned students and teaching and so on, so it kind of came back to me. When I was a student, I always said to people who were around me, like fellow students, it's like a boot camp in the army here right now. And
Yes.
I and then you mentioned this person, Sarah, had to stay longer than she wanted to, and then she had to quit and all that. So like everybody understands there's a huge problem. And even in the academy, at least from my perspective, my particular place, what I remember, it kind of was that you cannot be late. You cannot be late to your clinical shifts when you're a student. You cannot be wrong. You cannot do one, two, three, four, five. And people were punished on the very slightest of I don't know, misbehavior, which is not
Yeah.
misbehavior. It's like, I don't know, I was 5 minutes late to the beginning of my whatever. And it was a preparation stage. This is how it's going to look when you get to your actual work. My
Yes.
friend, get used to it already.
Yes.
And
That,
the system kind of preserves this tension within itself because everything is stressed, everything is collapsing. Wow,
yes.
it brings up memories.
Yeah.
Now, one last question. We don't
Sure.
have we don't have all the time in the world, unfortunately. If you could change one major policy to fix nurse retention, what would it be?
Well, I didn't mention this earlier, but I sit on two legislative committees for our state here, and I see a lot of the legislation going through. And if I personally had one shot, I'd go all in on opening up an affordable education system to flood the pipeline of nurses. We need to get them through the system. That engagement needs to start early on in high school and keep them engaged through the system. Forget the rigid fixes like ratios. I know they sound good, but they don't deliver. They just do not deliver. It only causes more financial hardship on the healthcare facilities. They just shuffle the same short deck of cards, if you will. Instead, I think it would work if we could slash tuition cost, pump funding for nursing schools and educators in nursing. That is something that doesn't exist. And crank out more grads. Think of it as a widespread scholarship, online programs, real clinical, tie-ins, and loan forgiveness that kicks in maybe after a couple years on the job, not right away. Look at states like Texas. They're expanding community colleges in the nursing track, and it's filling large gaps without breaking the bank.
Nice.
Retention is better when nurses aren't unicorns, and right now we're hard to come by. More hands means less burnout, and the job feels doable. It's not about perks, it's about building an army so that no one is fighting alone.
Yes, I could not relate to that more. Well, Thank you so much, Heidi. It's been my pleasure talking to you, and I learned so much, and it actually brought up so many memories. And this is so important to talk about and share with everybody else. I
Well,
really thank you for your time.
thank you so much for having me, Sergey. It was a pleasure of mine, and I look forward to continuing our collaboration.
We will. We will. Thank you very much and have a
Thank
great
you.
day.
You too.